Let's have a look at the upper extremity venous anatomy and the veins we'll be assessing during a DVT. Alright, so the upper extremity venous anatomy varies slightly from that of the arterial side. The major difference between the venous system and arterial system is that there are two brachiocephalic veins and only one right brachiocephalic or innominate artery. Just going to draw your attention here to the right and left brachiocephalic veins. We're also going to look at the internal jugular vein and external jugular vein. The external jugular vein is a very superficial vein. It has no associated artery running with it, and often we don't recognize it while performing a carotid study because the pressure that we use collapses this superficial external jugular vein. We're also going to assess the subclavian vein and the cephalic vein. Again, the cephalic vein is a superficial vein and has no accompanying artery. It runs along the lateral aspect of the arm. I'm just going to bring your attention to it. And up in through the bicipital groove, joining the axillary vein actually to form the subclavian vein. We're also going to have a look at the axillary vein and the brachial veins. There's usually two brachial veins and the basilic vein. It too is a superficial vein and does not have an accompanying artery, and nor does it run deep in the muscular fascia. So I just want to draw your attention here to the brachial veins. These join with the basilic, the superficial basilic vein, to form the axillary. The axillary joins the cephalic to form the subclavian. The external drains into the subclavian, and the internal jugular and subclavian join to form the brachiocephalic. And we'll reiterate that through this podcast. Okay, so let's have a look here at the central veins. So central veins just means in close proximity to the heart. So there's going to be a large cardiac influence when we're assessing these veins. So again, the internal jugular and subclavian vein are considered central veins. They join to form the right innominate or brachiocephalic vein. The left internal jugular joins the left subclavian vein to form the left innominate. Note the horizontal position of the left innominate. It is much longer than the shorter and more parallel right innominate vein. So that right innominate vein runs very up and down or superior inferior, and the left innominate travels a more horizontal path. The right innominate and left innominate join to form the superior vena cava, and of course that superior vena cava is draining into the right atrium. So we can see the right atrium right here, and the close proximity causes a large cardiac influence in those central veins. So we can position the patient supine for the study, or we can actually have them sitting upright. There's many ways to position the patient, and we'll explore those opportunities and positions in the lab when you're here at BCIT. All right, so the neck veins, we want to have the patient in a supine position, because if we have them sitting upright, the natural tendency is for those veins to drain and collapse, so it's very hard for us to assess them well. So having the patient lie supine for the neck veins is a good idea, and then sitting the patient into an upright position, let's just note that down. Supine for neck veins, and upright for other veins. So when we sit the patient upright, it also causes an increase of hydrostatic pressure and helps to dilate those peripheral veins. All right, let's have a look at the central veins. So the emphasis is really on the Doppler or spectral tracing for the innominate or brachiocephalic veins and subclavian veins. So those veins are very difficult for us to compress. We can sometimes position the patient and compress the subclavian vein, but we're also working against that clavicle, and it can be uncomfortable for the patient. So often we have to rely on the spectral tracing. The central veins that are easier to compress are those neck veins, the internal jugular and the superficial external jugular vein. I'd like to draw your attention to the spectral tracing. This is taken in the innominate artery. The innominate vein, and we can see systole, diastole, atrial kick. So we have that really strong cardiac influence. So the pressure changes that are happening in that right atrium are reflected in those central veins. So let's draw your attention to the left-hand side of the screen. And the yellow line there just identifies the area that this image has been taken. And we can see the associated artery here, the carotid artery. And more lateral to that carotid artery, we can see the internal jugular vein. So this is one of the neck veins that we need to assess. On the right-hand side of the screen, we only have the artery remaining. So we can tell that there is no thrombus within the internal jugular vein. So internal jugular vein is easy to assess. We have easy access to it, and we can assess it well in 2D and compress. The other thing that we can do if you're having trouble compressing or the patient is uncomfortable, a quick sniff test will help to collapse that vein. So that's something that we can play with in the lab as well. Now I want to draw your attention to the superficial external jugular vein. This is the vein I spoke about that it often gets compressed while doing a carotid ultrasound. It's a little bit more lateral to the internal jugular vein and sits in that superficial fascia here. And I just want to draw your attention to the ultrasound image of it here. So you can see that ovoid shape there. And on the right-hand side of the screen, it compresses. So again, we must float that probe very lightly and have a look. And an interesting fact is not everybody has an external jugular vein, but if we start to look for it, you will be able to start to identify them. All right, now I want to draw your attention to the brachiocephalic vein. So the easiest way to find the brachiocephalic vein is to identify that internal jugular and slide more proximal. Remember, proximal meaning closer to the heart. So we will slide more proximal or more inferior. And we're going to look for the junction of the brachiocephalic and subclavian vein. So here we have the subclavian vein joining the internal jugular vein, and this steep portion here is going to be the brachiocephalic. So the brachiocephalic is very hard for us to assess in 2D, so we can use color and Doppler tracing to assess that there's nothing happening more proximal to that area. So again, the internal jugular and subclavian veins join to form the brachiocephalic veins. So once we found that, let's go back there, we're going to angle our probe more inferiorly so we can see a larger portion of this brachiocephalic vein. And then again, note the strong cardiac influence, systole, diastole, atrial kick. Systole, diastole, atrial kick, that backward W there. So we want to make sure that we see a nice strong cardiac influence and that the right atrial pressure changes are reflected there. Okay, now we're going to follow the subclavian vein, and this can be seen from a supraclavicular window or infraclavicular window as well. This one is just going to demonstrate the supraclavicular window. So we want to slide lateral from the internal jugular and rotate our probe to elongate that subclavian vein. And we're just going to kind of slide lateral along the edge of the clavicle, and angle inferior. So here we can see the subclavian vein elongated. Blood's moving towards the probe here and is starting to tip away because it's all heading back to the innominate and eventually the heart, right atrium. And again, we have this venous waveform here, and we can see some of that cardiac influence. Not quite as strong as what we see in the innominate, but we can still appreciate the systole, diastole, and then we have this little reversal here of atrial kick. All right. So now what we're going to do is slide infraclavicular. So we're going to bump up over the clavicle and angle a little bit more superior. We want to elongate the subclavian, and then we're going to rotate the probe clockwise to identify the cephalic vein. So it's important to identify where the cephalic joins the axillary vein to form the subclavian. So we can see here this is going to be the cephalic vein. It's traveling more superficial, and remember this is one of the superficial veins. So it's going to travel up and eventually come down through that bicipital groove here. Let's just use a different color, just along, see if we can use green. Yeah, right in here through that bicipital groove. And then below this, we have the axillary vein right here. So basically, this is the location of what we're seeing. But we have the probe steered to the right, so we can fill the cephalic vein and identify if there's any thrombus in that junction. Okay, so for the arm veins, we're going to emphasize our study on the compression part. So arm veins are easily accessible, the distal arm veins in the peripheral limb, and we're going to compress them. So this is a good time to sit the patient up. Then we're going to abduct the patient's arm and rotate it externally to access that internal portion or medial aspect of the arm. So we're going to assess the brachial veins. It's easy for us to identify because it has an associated brachial artery. And then we're also going to look at the basilic vein, that most medial superficial vein, because it has no associated artery. And again, it doesn't run deep in that muscular fascia. Okay, so basically in this image, all we've done is steered the box to the left to assess the axillary vein now. And we can still actually see that cephalic vein quite nicely. So the cephalic and axillary join to form the subclavian vein. And if we look at the color, blue is going towards the probe, which means towards the probe, which is the right direction, back towards the heart. This will be more medial, and this is more lateral. All right, and in the axillary vein, again, we can see some of that cardiac influence, and it's a very pulsatile waveform because of the proximity to that right atrium. So in our leg veins, we don't see quite as strong a cardiac influence because it's further away from our heart. So we want to see this pulsatility. Okay, now let me draw your attention to this tiny little vein here. This is the cephalic vein, and this is coming from a more lateral aspect, somewhere near the bicipital groove area, and it too compresses very easily, so you have to float the probe. Remember, the cephalic is a superficial vein because it has no accompanying artery with it. This can be a little bit more tricky of a window to identify the cephalic veins. You guys can play with it. But the most important part is the confluence at where it joins that axillary vein. So if there's a thrombus closer to the deep system, then we're more concerned. All right, then we are going to come mid-humerus level. And we can actually identify the humeral shadow there. Whoops, let's go back. Humeral shadow here and here. All right. And then I want to draw your attention. We can see some vessels here, and I can see one over here. So the basilic vein is superficial and sits by itself and is more medial. So this is going to be the basilic. And then we're going to have the brachials. And often there are 2 brachial veins, sometimes even 3. Right, and then I'm assuming this is probably the artery. So on the right-hand side of the screen, again, we have 1, 2, 3 vessels that compress, and what remains is the brachial artery. All right, let's have a little bit closer look with color. So if you're having trouble identifying them, we can go mid-humeral level, identify the humeral shadow, and then we have the artery here. And we have the 2 brachial veins. So they're traveling along with the artery, and then more medial and on its own, because it's superficial, is the basilic. So on its own just meaning that it doesn't have that accompanying artery. And remember, the basilic sits more medial. Brachials are sort of mid-arm, but lateral to the brachials, and then very lateral is the cephalic. So there's a little helpful hint here. It's the A, B, C's. So if you get confused about which is which, the basilic, it works alphabetical, moving medial to lateral, brachial, and cephalic. So from medial to lateral, we have the basilic, brachial, and cephalic. Basilic and cephalic are both superficial veins, no accompanying artery, and not deep in the muscular fascia. And here we have the humeral shadow. There. All right. So this would be a diagnostic impression form. If there was no DVT, it's very easy. You just check no evidence of DVT. If there was a DVT, and let's say it lived in the brachial veins into the axillary, then we would draw in some thrombus into the axillary vein. And perhaps there wasn't any in the basilic. There we go. So we would just color in the area in which the thrombus was. And of course we would want to know occlusive or non-occlusive. Let's say non-occlusive thrombus seen in brachial veins. In brachial veins extending into axillary. So depending on your site, you may or may not write that out. They may want you to, or they may just want you to illustrate where it is on the schematic drawing. So just follow your site protocol. Okay, upper extremity hemodynamics. So again, we want to ensure that we have a pulsatile waveform in those central veins. If you notice on the right-hand side, you can see the pulsatile appearance here. So this would be systole, diastole, atrial kick. We could have it flipped. Sometimes with venous, they have it going to or away on top or below the baseline. There's less consistency, but if it was me, I would probably flip the or invert this so that the tracing was below the baseline, but that's indifferent. All right, so here we have a nice cardiac influence. On the left-hand side, you can see this flat flow, and we've seen it with lower extremity venous imaging as well. And we know that it means that there must be a proximal outlet obstruction. So for some reason, the cardiac influence has been taken away and it's very flat flow. So there's some kind of proximal outlet obstruction happening. So when we talk about proximal, we know that that means closer to the heart. So if we have a right subclavian vein, that is normal, and we have a left subclavian vein, that is abnormal, where is the problem going to lie? Well, let's see. Both of these join to form the superior vena cava, the innominate. So if we were to see an issue on the right and the left side, then we would know that there would be an issue proximal to both of their location, which would have to mean the superior vena cava. If issue with right and left subclavian vein, because that's the one vein more proximal to both of those veins. However, in this example, only the left side shows flat flow, indicating a proximal outlet obstruction proximal to the left subclavian vein. So the vessel that is proximal to the left subclavian vein and not the right subclavian vein, we can assume this is normal because the right side is not affected. So I'm just going to highlight in orange here, danger zone is going to be somewhere along the left innominate brachio or brachiocephalic vein. Somewhere along here there's going to be an issue. So it could be a thrombus within the vein. There could be some kind of mass effect pushing, acting like a thrombus, collapsing that vein more proximal to our location. So we have to think about where in space we are, what our findings are, and what lives more proximal to where we are. So I know that can be a little bit difficult to wrap your head around. But again, if we were to see this on the right and left side in the subclavian, what vein is proximal to both of them? Well, the left innominate isn't proximal to the right subclavian vein, so it has to be something happening at that superior vena cava level. And sometimes we can have heart masses, we could have lung masses, and you could have a thrombus somewhere living in there as well. So we have to be very diligent. It's up to us to identify, is the Doppler tracing normal? Is it abnormal? In a case like this patient would probably go on to CT imaging or a different type of imaging to assess the veins a little bit more closely and identify that exact location. So because of the proximity to the heart, we have to be very diligent to ensure that we're getting accurate findings, so there is an increased risk of that potential of a pulmonary embolus. It's so close to the heart. All right, effects of respiration. So when we take a breath in, we know that thoracic pressure decreases, then venous return to the heart increases. Well, venous flow return from the upper extremities increases because of that lower thoracic pressure. It doesn't have to travel through the area of the abdomen. So it's a little bit different than lower extremity venous return. So again, inspiration, our thoracic cavity size increases, which reduces thoracic pressure, venous return to the heart increases, and venous flow return from the upper extremities actually increases. When we breathe out, the thoracic cavity gets smaller, and this reduces or increases thoracic pressure. Venous return to the heart decreases, and venous flow return from the upper extremities decreases. So we have to kind of walk through it and just think about pressures. What's happening in the thoracic cavity is going to drive venous return from the upper extremity veins. So signs and symptoms that there is a thrombus or an issue is the same as lower extremity veins. Swelling, edema, so you'll get maybe more of a swollen hand and arm. It'll be tender. Skin redness, pain, tenderness, and again, chest pain as well if there is a pulmonary embolus. More unique causes of upper extremity vein DVT now is the use of catheter placements. There's an increased use of the PICC lines or peripherally inserted central catheters, also pacemakers, a lot of needle punctures. There is a rising population of IVDUs or intravenous drug users. We also have a syndrome that we're going to talk about, the thoracic outlet syndrome, unique to the upper extremity veins, as well as a rise of breast cancer, and breast cancer treatments can cause lymphedema. It can cause that lymph system to break down, and then we get arm swelling because of the poor lymphatic drainage. So mentioned on the previous slide, just the causes of upper extremity, the use of the PICC lines. They're a great way to be able to give IV drugs, and patients can walk around with those PICC lines and have more of a normal lifestyle, especially if they're going through cancer treatments. In the lower extremity, stasis is often the #1 cause for lower extremity DVT, and vessel wall injury is #1 cause for upper extremity DVT because of the increased use of PICC lines. So if somebody comes in for PICC line, what we have to do, we're trying to find, you can see kind of these little faint parallel lines here. We're assessing all along those PICC lines. They'll sometimes insert them into the basilic and then guide them up. So it's important that we will identify and follow those lines as best as we can see. And then we want to compress as well. You can see them here in transverse. These aren't the greatest examples for you, and I apologize. They're hard to come by. So when you compress, that PICC is still going to be seen, and the vessel walls are not going to completely co-op because they have that central catheter line in there. But what we want to be sure is that there's no thrombus. So here you can see the PICC line below, these parallel lines here. So usually they have 2 lines in them, and then we can kind of see this thrombus beginning to form on here. So this patient would need to be treated. So that one's it's a little bit better of an example. So here we have Paget-Schroetter syndrome, or you may hear it referred to as thoracic outlet syndrome. And it basically is an effort thrombosis. So it's caused by repetitive strenuous activity of the upper extremity veins. Gymnasts, people that are rowers, swimmers can often suffer from this. So it constricts the subclavian vein, and causes endothelial trauma. The effects of the repetitive strenuous activity causes an increase sometimes of those scaling muscles as well, but they also realize that sometimes it can just be an abnormality in that area, and these people can have a narrowed costoclavicular space. So just that area of this first rib, hang on here, oops, let's see, this is going to be the clavicle. And this is just the first rib here. There we go. So it just gets pinched in between that clavicle and the first rib space there, causing that endothelial trauma. And so often there will be what they call an effort thrombus forming. So we have to be really diligent about assessing the subclavian and axillary veins if a patient comes in with repetitive activity and is complaining about that, and it increases when they are being active. All right, and breast cancer patients. So this is just an example of somebody that has arm swelling. They can have numbness and tingling. So the effects of the radiation actually damage the lymphatic system, and lymphedema can happen because of the poor lymphatic drainage, as well as there can also be a DVT present. So again, we have to just be really diligent about compressing veins, identifying spectral tracings, what's normal, knowing what isn't normal, and understanding some of the causes of these upper extremity venous DVTs or arm swelling. All right, that wraps up the upper extremity venous anatomy and DVT tutorial.